There's a hard cutoff at, I'm assuming, 11:30, 12:30 your time.
Yeah. And
Interesting.
if we can keep it going till then, great. And if we get done, before then, that's fine too.
Perfect. All right. If you could give just
Either way, I'm charging you the same amount, Chris. So
great. I love that. All right. So if you give just a brief intro on your background, and then we can roll from there.
sure. Hi, good morning. My name is Steve George. I am currently at Duke University. I'm a professor at Duke. Been here since 2016. Clinically trained as a physical therapist way back in the days of the bachelor's degree. Worked clinically in the University of Pittsburgh Medical Center for 6-7 years, pretty much full-time clinically, and started to get interested in research. They had a PhD program at Pitt, so I stayed there and finished a PhD in 2002. After that, I went down to the University of Florida to do a postdoctoral fellowship in pain research. I will remind you that this is way before anyone thought doing a postdoc in pain research was a good idea. This was well before pain neuroscience education. This was well before pain science. I mean, there was a science of the study of pain, but it was not linked much to clinical practice. So timing is everything in life. That ended up being a pretty smart move by me. Some people think that's because I'm super smart and strategic. I'll tell you that's not necessarily the case. It was just a lot of luck. But I studied there, learned a lot about quantitative sensory testing, and I had already started some study of the psychosocial, so it allowed me to continue that. It was in a clinical psychologist lab, Mike Robinson, which was really great, actually. And since then, I've been working on a research career. I was the program director at the University of Florida for a couple of years for the DPT program, and I transferred up here to Duke to more or less have more time to focus on research. And I have a role in the Department of Orthopedic Surgery. I also have a role in the Duke Clinical Research Institute, and we have a really good research team right now. So that's what we're doing, and I'm happy to talk to you about some of the papers that were sent out. And I'm just going to tee them up, I think, with a couple of slides, and then hopefully we'll lead into some discussion, questions, answers, however you want to do it.
Yeah, perfect. Thanks for that. And I let you share your screen so you can pull that up.
Thank you. All right, let's see if it's going to let me do this. Does that look all right for everybody? This is March Madness. For me, is a bunch of students wanting to do a Saturday Journal Club. That's why I titled this the March Madness Saturday Journal Club. Of course, the real March Madness will kick off tomorrow for Selection Sunday. So hopefully your team, if you have one, makes the bracket. So what I did is I am going to pull out some of the key visuals. Shoot, I'll go backwards. From the three papers that I tend to be kind of a visual learner, and I will try to maybe make a story out of them, at least how they made sense to me yesterday when I was putting these together, and then leave most of the time for questions, answers, and discussion. So with that in mind, I thought this table in the Pain Reports paper was really interesting because I think these authors did a really nice job of precisely defining the language they want to use. And I think that's really important for clinical audiences, because these tools that people develop often have a very specific purpose, and sometimes there's drift in the language. So the term prediction model and stratified care and treatment decision rule, there's some overlap there, but there's also some specificity. And I thought if that hadn't been emphasized yet, it's a pretty good take-home message, because you can see they are each related to different clinical questions. in italics there, what is the likely outcome of this patient with this treatment in this setting? That's a prediction model or a prediction rule type of question. Which care pathway is best for this patient is more of stratified care. And that's, the Start Back tool is the one that a lot of people use as an example for stratified care. And then which treatment is likely to be most effective for this patient is more of the treatment decision rule. And I do think sometimes people, get those, linked together in their brain. And I just liked how this article made you think about, how these questions are different and what tools you might use to answer those questions. So we can come back to this. I don't know which one, as a student, which one you're most interested in. I think what happens is we're really interested in that last one, which treatment is likely to be most effective for this patient, but then the research is better at building the first two. So, that is a potential disconnect there. And then they put together this nice model of, and you'll see some themes with this, this kind of basic care, more of an individualized approach, and then a more specialized approach. And you're kind of going from a lot to some to few of the patients. And here they're putting on where risk stratification occurs, where, and how that may guide, subsequent treatment. They're also trying to combine, stepped care with stratified care, which I think has some important elements. And again, that's something we can talk a little bit more about if people have an interest in that. What is so that those, I think, yeah. So kind of along the same time, I mean, these papers were published very similarly, very much at the same time, and they cover similar topics. We had been thinking about this. I've been involved with some pragmatic trials, and have been thinking about, what you need to do to reinforce guideline concurrent care in common settings. So I was fortunate enough to lead this paper with some co-authors. We started thinking about, what are ways that we can structure care so that it's actually delivered the way the guidelines intended, instead of, you kind of having, as an individual provider, having to always go upstream against the current, to get the guideline concurrent care. So we broke this up into kind of before care seeking, during care seeking, and then the care delivery aspects. And we came up with, again, something very similar, but this one is more specific to back pain. I think it also is meant to be mapped on to health systems in the US. The prior article, those authors are all in the UK. So you can see, very similar to what they had for Care for All, we have this step called foundational back care. And really, we think everyone should get education and everyone should be encouraged to do self-management. So that's kind of like our all step. After that, we had, for the people who aren't improving with that, there's an individualized back pain care. This is probably where PTs would hopefully thrive, where you're identifying treatment moderators. These are the things that people are going to have better or worse responses to. And what is interesting for the US health system is this should be heavily non-pharmacologic. And we know that doesn't happen when you look at the data. And then the final step is the specialty back care. This is when, maybe other more invasive or interventional things are being considered. And this should be for the select few who don't respond to the first two steps. On the right, the other thing that's missing in the US is, what can we refer people back to reinforce their self-management? And we were thinking, if people, and I think some of this will be developed by health systems and some will be developed by communities. These are the types of skills that are needed to manage pain conditions, and actually quite a few other chronic conditions. So there's probably some overlap here with other chronic diseases, nutrition, sleep hygiene, stress and mood, social roles and work. Those are not specific to pain. In fact, the only button there that's specific to pain is the pain coping skills. So that was our, attempt to map this on to the US health system, which was an interesting exercise. And then the final paper, which was led by Trevor Lentz, is, if you think of it now, I think we're at that individual care level, whichever model, whichever paper before, we're at the individual care level, and what is the PT's role within that. And there's a lot of interest in, early physical therapy or direct access, but I think there's some nuances there, and that's what Trevor tried to illustrate with this paper. Is there's people talk about early access or direct access to PT, but those terms, first of all, haven't been very well defined. And then they also haven't been fully explored beyond their impact on opioid prescriptions. So this was our attempt to talk about, what is some language that we should use. And you can see we used early physical therapy system entry, and physical therapy treatment first. And all of these have been lumped together and described, the same way in certain studies. And we just wanted to tease them out because the health system demands and how these are implemented are very different. The other thing, Trevor was very interested in is, how do you determine the value of these? Is it always better for PT treatment to be in the early treatment phases? Are there times when it might be better to delay it? We've been pushing so hard as a profession to have physical therapy available early. There may be some, conditions or situations where actually the delayed physical therapy is a better option. And of course, what Figure 2 does is it contrasts it with the traditional care model that is available in a lot of systems. And then, kind of what we spent a fair amount of time conceptualizing, because I think this is what it boils down to, is, the emphasis has always been on diagnosis, and what value-based care is really shifting towards. The risk isn't that you're going to miss the diagnosis. The risk is you're going to be delivering unwarranted care that may add to a person's cost, may add to their mainly their cost, without improved outcomes. And this is the shift that we think is going to be really important, especially in physical therapy first type of models, because it's pretty clear in the evidence PTs do not systematically miss diagnoses. But what is less clear is, are physical therapists going to be good stewards of the services they provide? Can we be disciplined enough to say this person actually isn't going to benefit more? Maybe they only need 1 or 2 sessions versus I know I can get 7 or 8 approved, but the outcome is going to be the same whether we have 1 or 2 sessions or 7 or 8. And that's really what that shift is, from the present state to the future state. And in the paper, we talk about that most likely being a future definition of harm. That harm currently is defined a little bit differently, but in the future, I think is going to have more of a value-based definition to go with it. So those are the slides. We can go back to any of them. You can be done, however you want to do. But I just thought like I said, I'd kind of tee it up, put these papers in order. This is one way to consume them. I think you could start anywhere. We were talking before, these really triangulate well with each other. So I will open it up and, we'll kind of see what happens next. Thought my dog wanted to go out, but he didn't.
Hey, Steve, how's it going?
Who let him in? Oh my goodness. How are you, man?
Good. How are you?
Good. Very good. Good to see you.
Good to see you.
I missed a very late night with you in at CSM. You know, that's our tradition. So
I know. I felt like something was really missing mid-February this year in my life.
my
Uh,
headache. There was a noticeable lack of headache though too. So that there is that part of it.
yeah, there was a weird clarity through the middle of the month that I wasn't accustomed to. So one thing related to these papers that I think is like worth discussing, and you certainly have an intimate knowledge of, is kind of the evolution of systems for low back care, especially like where treatment-based classification was born from and the hill it ended up kind of dying on. That's Chimera. She's wanting to sing a song of her people right now. But I think if you wouldn't mind, just kind of take us through the history of where PBC first evolved from and then what it's emerged into now.
Yeah, I think, and you know, I assume there's some familiarity with the treatment-based classification system that Derek mentioned, but you know, I think that and other systems like it really evolved from the lack of diagnosis in the spine being really meaningful for guiding treatment. You know, you could have multiple people with very similar anatomical findings on imaging, and it really didn't help with clinical decision making. So the treatment-based classification was a reaction to that, to the not having diagnostic tools that guided treatment decision making. And it really started with clinical intuition. You know, the story is that Tony Delito and Richard Earhart and Rick Bowling just kind of got together and they talked about what were key decisions that they made, and they kind of funneled it down to, you know, there was 4 or 5 different patient types that they could identify through movement testing, you know, through at the beginning of it, there was palpation and landmark assessment. And, you know, they just basically provided some guide rails. You know, if your patient looks like this, you might want to consider manipulation. If your patient looks like this, you might want to consider like repeated lumbar extension. If your patient looks like this, you know, traction. So they were moving those diagnoses of lumbar imaging and even some of the special tests. And I think what they did is they started moving the ball towards the people being aware of the prognostic factors driving the clinical decision instead of the diagnostic. Like if knowing someone had a herniated disc was not useful, then what was going to be the next step? And it became more you know, more about identifying prognostic factors. So then, you know, they had the curse and the blessing of being in a very science-driven environment. So they had, you know, they had the wherewithal to start testing these things, and some of these things panned out and some didn't. I mean, anybody who has done research knows that you're going to die on several hills, not just one, Derek. You're going to die on a lot of them. One of the things that became fairly robust was, you know, the psychosocial factors were really good at predicting outcome. And that was not unnoticed. And that's one of the main, you know, that is the linchpin of stratified care, is that you can fairly reasonably stratify people based on psychosocial distress, especially in back pain. And you can have an idea of who has a poor prognosis and who has a pretty good prognosis. And that is independent of their physical impairment levels and all kinds of things. So, you know, we kind of went from diagnostic-based to treatment-based classification to then more of a prognostic model. And then I think, you know, what the Comstead, like that has Jonathan Hill. I mean, that's essentially some of the Keel group from the stratified care. What people are messing around with now is how do we combine, you know, the stratified care with other care models that allow for some tailoring, some individualized care, which is ultimately what treatment-based classification was. So I think they're revisiting some of those aspects without using that language and probably testing, you know, different models. Does that kind of make sense, Derek?
Yeah, I think just from an evolutionary perspective, it's good to kind of know where it came from because it still is hanging around in different iterations.
Mm-hmm.
And I think for this group, especially, what you would probably hear as a consensus is I think you articulate it really well in your slides, an overemphasis on diagnosis versus prognosis. And I even think with TBC, it gets misconstrued a lot of times in its implementation to what treatment does the person need versus what's the overall likelihood this person's going to get better regardless.
Right. And those are hard, that's why that first slide, those are really hard to disentangle sometimes, right? Because you can't treat the same person with multiple treatments at the individual clinical level. So you don't really know if they, at the individual level, you don't really know if that person just happened to have a really good prognosis and they were going to get better with anything, versus you selected the treatment that allowed them to have a better outcome. There's some studies that try to tease that out. And we know in back pain, those studies, they often show that the prognosis is the overriding factor and the individual treatment, has a smaller impact on that.
Question for you. Do you think that we've been kind of researching, at least in the American care model, too much on interventions done by clinicians and not enough at the community level? Because both of Kongsted's and your paper with Christine Gertz started with the right side of the graph being, community level stuff, physical activity, promotion, and all those things. And Kongsted, she's over at SDU, which is where GLAD comes from, right? So they have this idea of like, you come in, then you go to group exercise and education first. And if that doesn't work out, then you see a clinician. But we don't really have that model in America, or the option for that model, right? Like if you are seeking care, there is no group exercise or group education idea. And that's kind of what we've seen with the CFT versus group exercise trial, right? Like if CFT is relatively maybe the best we have, it still doesn't do better than group exercise for the average.
Yeah, no, I think, yeah, you're right. I mean, that's another evolution that's occurring is, when do you need the individual skill of the clinician versus when is there just kind of a general benefit of doing the activity. And yeah, I think, the US model has always been built around the fact that you intervene at an individual level. I think that's also because it's always been predicated on you need a specific diagnosis and there's a really defined action that occurs right after that. It's built on a germ disease model, basically, right? It's built to tackle coronavirus. It's not built to tackle back pain. Can you imagine if the cure for coronavirus was for everybody to do group exercise and things like that? We'd be really sunk. So, I think that is a good observation. And obviously, in the US, what we're trying to do and others are trying to do is to say conceptually this makes sense. We know you're not going to be cured of back pain, right? You're not going to be cured of any musculoskeletal pain. There's probably periods where you need access to specialized interventions or individualized interventions. But what would also be nice is when you're done with that they could kick you into, like a step down lightly supervised session, or environment that enhances the self-management. People have done a reasonably good job with this in diabetes, and there are some communities that have done better with like heart disease. And I think that's what it's going to take is for people to, buy into chronic pain really being a public health problem and, not think it can be cured with, 2 times a week for 6 weeks, with a PT or a chiro or whoever. But like you said, we don't have those systems. I think people that are interested in them are starting to explore them. It always in the US comes down to, who's going to pay for those to exist and what is the margin on that? Because healthcare in the US is a business. And they're part of the reason we don't have those in the US is there's probably not a clear business plan model to do that. If there were, I think it would already exist. So I agree with you. And I think you pointed out some great examples. The VA does a good job with this. The VA has different incentives, but their whole health program is something else we pointed out in the paper. And it will be really interesting to see if some other large health systems in the US start having, similar types of programs where people can have access to a wide variety of holistic, options, and they can kind of select, what they have access to and when they have access to it. Was that okay?
Yeah, no, that kind of fits. So I'm conflict of interest here. I'm running an SR on community-based versus clinician-based interventions for back pain, and it's looking like there's not much difference
Yeah,
on these things. So it's like, but then we also look at where they are, and it's like not in America, right? And even though
right.
we tried to play with the definition of community-based because it wasn't very easy to define, and we kind of decided on anything that could be done outside of the healthcare system, even if in the trial itself it was done, like let's say a group exercise was done by a PT. As long as they didn't need an assessment, it was just general group exercise, we consider that a community based because that could be done by anybody, right? Technically. And we're not finding much difference in
Yeah.
outcome.
Or do you have enough of the patient level characteristics? Do the patients look different? Are the people seeking care more severe, or
So
are they pretty comparable?
So we are going to do, that's our secondary analysis to see if we can even pull a meta-analysis enough because it's a lot of trials,
Mhm.
but a lot of different people, and we'll see what we find there to see if we can find any type of subgroups.
Because I think I would not be shocked, obviously, if if it ends up where you say, but I would be, if I were reviewing that, that would be kind of my other kind of question would be, could you characterize these patients enough in the different settings to get an idea, where it was one more severe than not. We do know in the US, and I think in some other in European, people who seek care do tend to have, higher levels of disability and pain and things like that, which unfortunately are also prognostic factors for not doing as well. So, well, that'll be interesting to see. Good luck.
Thanks.
I have a question. Hey, Stephen, this is Dan King out here in Newburgh, Oregon. I work with Jeff Hauk. So
How's it going?
it's good to see you.
Yeah, good to see
Hey,
you.
I have a question for you. How do you think it's going to impact education as we're kind of going from, because we both teach. And so one of the questions I get is, we've been going really hard on the CPG with the treatment base. I just talked to Joe Gajas. And then, but I see this happening with the step care, prognostic. So the biopsychosocial has been really big, right? And we've been trying to incorporate that. And Jeff and I have been working really hard with that, and then using Promise and also the Keel Start Back to on the MSK and then on the OSPRO as a way of kind of grouping it together.
Right.
And so we're doing the treatment approach and they understand that. But how do you think education will change as we start becoming more of what we could say is direct access or primary care, or all these things that we're trying to do to be the entry point for all MSK that's coming through? I guess that's my number one question. And then the second question is, how do you see this dealing with the post-professional education when you're dealing with big companies, that are out there who are invested in more of a fee-for-service type of approach?
No, it's a great question.
Yeah, especially when they're going from our programs out to clinical practice and applying for jobs and getting super confused on, here's the didactic or here's our training, but then we go to a clinical training and things are kind of, not gelling yet. How would you go about dealing with that?
No, it's a great question. And, I think I'll give you my answer. I don't know that I have a good way to fix it, but I think, what I view, and I've been told I'm dead wrong on this. So, that this is, I'm letting everyone know that my view is I think I think the skills will be more about giving people options and giving people basically probabilities that go with those options. I think people have become so much more sophisticated with forecasting and predictions. And these are the same people that are doing projections of their like 401k. They're doing projection, there's a much wider swath of the world that is comfortable with that. And, I think PT has been kind of accused of failing to use some of that technology. And there's people that get more sophisticated input from their smartphones, right? And what they're wearing on their watch. And then when they come to PT and we're like, looks like this is higher, I think I see people that are willing to embrace the technology, willing to be a little bit more humble about what their individual treatment skills are, but fully embrace, that prediction apart. And when I talk to my students, it's, we're giving people the information of whether they need to bring an umbrella and wear a raincoat versus, maybe some of that becomes, and some of that should feed into the shared decision making, right? If you sit down with someone and you have your inputs and you're confident with your inputs and you have the outcomes that the patients are interested in. And what I think is the holy grail for me is, now, does my intervention drastically change that forecast, right? That's the one part where the weather falls apart. We cannot control the weather yet, unless you are, really into conspiracy theories, and that's a different journal club, as I understand. That one's probably led by Derek Miles, so we'll give him a little shout out. But I think that'll be the fun part is, can I tell you, if you come to 6 sessions, you're out, the likelihood of your outcome, where it looks like your outcome is really going to change, is between 6 and 8 sessions. So that's what we're going to work on. Now, how you get someone to pay for that, I think it's obviously becomes more like a group. It's less of this fee for service. I'm billing you for this. It's more, I'm going to manage this many lives. This is the system we're going to use. And these are the outcomes that we can get for this. We can't really predict at the individual level what the outcomes will be, but I can give you a reasonable prediction of that. So it will, it's a different skill set than what we give our students now and what they're tested on. But I think, and that's where I've been told, by the way, I'm wrong. There's still some people, and I think this is the challenge of being the movement system experts, is to me that there's parts of that still feel very diagnostic. And, I always argue, I don't think a patient comes to us to say, boy, your movement's crappy. I think they come for us to say, what do I need to do to avoid having crappy movement in 5 years from now? And, what patterns do you see that are indicative of, worsening function 5 years from now? Not this snapshot, look at what optimal movement could be based on someone who's like 23 years old, because that's what we do, is we try to make assumptions, and we have no idea what the variability of movement is, right? There are so many movement patterns that I think PTs intuitively say are maladaptive that probably aren't. So that's my long rambling way of answering. It's a very good question. I'm sure others want to jump in, but I think we become more like forecasters, projecting, and what's going to change, what's going to change that projection, and can, do I have the skills that will allow, and maybe it would be, community based, what model works best for you is 2 or 3 sessions. We get your pain, modified. We get your pain score and your disability scores cut in half, which we think we can do in 2 to 3 sessions. And then we'll move you to a community exercise program, and that will prevent your chance of recurrence. And, so that's what we'll put together for you.
That's great. Yeah, we've been noticing the same thing. So my kind of talking about my bias, or what I'm doing right now, is in primary care. So we're in primary care right now. We've launched a 3rd one, but the interesting target that the group that I'm working with went after, when you're talking about groups, was actually overuse of imaging. They had a huge issue being where we're at, and we were able to reduce it by 40%. And what was happening is the radiology group was very unhappy with us doing that. Very similar technique what Tim Flynn kind of experienced when he was doing his model out in Colorado. And so they were very unhappy. So they were trying to figure out, what they were going to do. But the great thing was that we had support from the COO, and he actually took it and he used it as a negotiation with the insurance group. And they actually increased the reimbursement to our program. Every time they used the primary care physical therapy approach, they increased it by over 150% increase on all of the things that they were going to do for MSK. So it's been a huge win, and we're seeing this this impact. But I think you hit it right on the nose. It's what you're measuring and what's targeted for that group. I think that's really important for them. And the opiates were actually within reason. It was much more about over-diagnosing and over-imaging, and then going for injections right after that. So we're starting to see the injections starting to change a bit, but that's a ritual, that's a habit. But the imaging has decreased, and we're seeing reward for the type of work we're trying to implement in the areas we're at. So
yeah, it's a great example. I mean, that's because that, like you said, almost the full circle part where it alters the reimbursement that's pretty rare. So that's really cool. That's great.
Yeah.
And I think you also hit it on the head where the top down support, you have to be doing it in a system where the top down support is there, because if you didn't have someone who's going to go to bat for you when the radiologists are complaining about their decreased collections, guess when it's going to end, right after that meeting.
Oh yeah.
So that's great.
Yeah, when I heard that the radiology group wanted to talk with us, I knew that it was either going to be a hard stop or it was going to be support from the group. And I was actually surprised the COO was the one that was like, no, we're going to value-based care. Like we're all about it. And we were able to have some really great dialogue with him, and he was highly invested. So
that's great.
Yeah, we've been very fortunate so far. So, thank you.
No, thank you. That's great.
Yeah, I have an asterisk sign. I started off. Do you still use QST, quantitative sensory testing?
We do in research. The clinical applications of it still aren't quite, as I think if you are going to use it, pressure pain threshold is about as good as you can do. And we had a colleague at Duke, who unfortunately passed away last year, Bill Maxner, who was doing pain phenotyping, and it was all self-report and the pressure pain threshold. So he still used that QST, and it helped him identify the clusters that they were using. But in research, we still use it for to try to get into some nuances of processing. But there was an article in Pain, I think, a commentary this week about is it time to give up on QST? Because I think I think it's when I went, the promises of 2002 have not been fully met. Do I think it's a helpful research tool? Yes. Do I think it's a helpful clinical tool? Not so much.
Okay, thank you.
Yeah, no, thank you. Are there other things in the chat? I can't dual task, so I wasn't looking at the.
No, there's not. But
okay.
Prior to talking about more of a forecasting approach with patients, more of a like probabilistic or percentage-based conversation with them, based off of like how many treatments you predict or what type of the history of how this will progress. How much caveat to give to those percentages or to that timeline if, again, it's based off of averages and a patient may take a lot longer to recover?
Well, I think that's the nice thing about the forecast. If you do the weighting, it doesn't have to be on averages. So there are risk calculators where you can input individual level factors. So I think that's where it gets really exciting, is you can have unlike the weather, which is the same forecast for everyone, you can have some individual level factors that really move the probability of the outcomes. You just have to make sure they're incorporated, and then it becomes, again, an additional kind of powerful way to engage the individual that you're working with, because you can say, based on some of the information you gave me, this is your forecast. This isn't a forecast. This is your forecast. So, you know, I definitely would advocate for using the types of approaches that there is, you know, the individual level factors. Now, the problem with that is, and this is where I think it really gets sticky, is that also means then you're going to have more uncertainty in your estimate. So that means, you know, you may, for some outcomes, you may have a range of outcomes that it's not as meaningful of a forecast as it would be, you know, with like a narrower confidence band. And you can play that either way. You can tell that patient, that means there's a lot of room for you to change. You know, you may have more control over this because it's not, you know, it's because we're not, you know, we don't want these forecasts to be felt like, you know, that it's everything is predetermined. This is, to me, just an indicator of like, you know, what is your likely outcome? Where are the areas we are most likely to be able to intervene to make a major change in that outcome? And I think that's one of the things like the StartBack tool have really helped us to understand is there's a good chunk in most systems. It's like 30%. I don't know what, you know, Daniel, what they found in Oregon, that are low risk, and it really doesn't matter. You know, you can minimally intervene with these people and they're going to do fine. Like their outcomes are going to be, and we as a profession have made a living of over treating those low risk people and patting ourselves on the back and saying, you know, didn't I do a good job? And that's one of the first things we talk about when we talk to PTs about psychologically informed practice is this is not about turfing the high risk patient away and focusing on the low. In fact, as people get more savvy with value-based care, those low risk people are going to go to the community. They're going to shunt them away as fast as they can to community resources because they know, you know, these people have a very good prognosis. So, and short of taking them in, imaging them, telling them their back is wrecked and there's nothing they can do about it, you know, and putting them on bed rest for 3 weeks, you know, that's the way to have someone who's low risk not do well. So does that kind of address that? You know, use the individualized forecast and use it as a way to engage. Most of the students, when I taught evidence-based practice, which is a mixed blessing because, you know, about 25% of the people enjoy that class, DPT students. And I got a lot of pushback from students about probabilistic thinking. And that's how I started using the weather, because I told them, I'm like, every day you do probabilistic thinking. It's called a weather forecast. Like if the weather person came on and said, today it's going to rain, now back to sports, you know, people would hate that. When you think of some of the information nowadays they give for weather, it's pretty sophisticated stuff. You know, they're given percentages, different times of the day, different amounts, you know, heat maps basically. So, you know, it was very helpful in engaging the DPT students to say, you know, you're already doing this. So all I'm asking you to do is be as sophisticated as you are, as, you know, trying to decide whether you're going to wear a poncho to the Gator game on Saturday. Like that's all I'm asking you to do. And I think that helped some of them. So instead of 25% of them liking it, now maybe 33% of them liked it, you know, after that. But, you know, that there's only so far you can go on EBP.
I have a question kind of related to this discussion. It seems like, so full disclosure, I'm a new grad. I'm employed by a company that really pushes every patient needs at least 15 visits, which is a bunch of crap. And they're also one of the biggest sponsors of CSM this year. So woohoo.
Yeah.
Welcome
to the business, right? Welcome to the business end of things, right?
So it seems like as a new grad, I'm kind of in a bind because if I have my low risk person, I get pushback, you know, on, oh, you're not seeing them enough because I discharge them in 2-3 visits and they're happy and I'm happy. And I'm fine with dealing with that end of the spectrum. But then on the other hand, when I get these patients with 10, 15, 20-year history of chronic pain and all these maladaptive beliefs, and they want aquatic therapy. And I'm like, no, that's not what you need. And how do we view that through the lens of value-based care when the patient expectation does not match what I deliver? And when we look at this through this weather forecast lens, it seems like a pretty bleak forecast for them, especially when we look at, you know, those psychosocial factors, particularly socioeconomic status, lack of social support, maybe they're on disability. it seems like then that just leaves the individual clinician in a little bit of a bind of the people that like would be easy to treat. I ethically don't want to be seeing all the time in clinic, and the people that want to be coming in all the time are people who don't want to be treated the way that they probably need to be treated and aren't willing to go outside of this private practice to get, you know, a behavioral health consult, that sort of thing. Does this research speak to that conundrum at all, or is that something that we just need to keep muddling along through?
Well, I mean, so let's start at one end of the spectrum. You know, I worked in, and this was in the 90s, I worked in a clinic where I was way below the average number of visits. And they reminded me of that. You know, so one of the ways to do that is, you know, to just keep them moving. You know, if you're going to discharge people early, just make sure you're keeping up with the evals. You know, I always had people ready. So, you know, that's the way, for me, that was a lot more tenable. I worked in a setting that was very unique. It was in downtown Pittsburgh, and it was a satellite clinic. And I had lawyers who would, it was a lot of legal, a lot of banking. So I had people who, you know, they were like, as soon as they sniffed they were plateauing, they wanted out. So it was almost like, you know, the opposite pressure of what you're dealing with, but the outcome was the same, because I still had the people who were paying me saying, boy, it would really be nice if you could average 6.8, you know, visits instead of your 4. And, you know, what I told them, you can't use this, but I did tell them, I said, well, a lot of these people are lawyers, and they're going to sue me if, you know, because they're, you know, they're talking to me about their medical malpractice suits and, you know, and things like that. And, but I do think you can control that end a little bit better. And it may just mean that you're reassuring them that, you know, when you discharge someone, you're ready to take on a new patient. So it all kind of keeps that continuity flowing. You know, the higher risk person, I think, is a little bit more challenging because, you know, it may be that instead of trying to do everything, you know, you pick the things that you think you can deliver at scale in your clinic. And it's, you know, it's probably not the social determinants of health behavioral thing, but it may be some, you know, maybe it is spending a little bit more time on educating about the beliefs of activity. Maybe it is getting them into, you know, an activity program that they will sustain. And I think, I always think, you know, there are some confines, obviously, and you just given a nice, you know, real world example, but how I use that time is still directly under my control. And as long as I feel like I'm using it in the patient's best interest, you know, then I can defend that. So don't make the new grad mistake of I have to fix everything for this person with a 20-year-old or 20-year history of chronic pain, but let's sit down with them. Let's pick 2 things that, you know, 12 sessions, this person, you know, and I usually set the tone pretty early. Listen, we are only going to have X number of, so this is what we're going to work on together. And then you can kind of work towards that. Then near the end, you can let them know of other resources as you get to know your community and other healthcare providers, you know, the other resources that they can go to. And I got really good of, you know, letting people know this is the end of your PT, but this isn't the end of your improvement. This isn't the end of your, you know, if you have more interest, there are other providers that you can go see. And, you know, go see that acupuncturist, go see the chiropractor, go see, you know, because they may tap into some things that we weren't able to. But I do, you know, when they left, I wanted to make sure there were a few things, concrete things that, and I saw a fair number of patients with fibromyalgia. And I moved pretty quick from, you know, trying to do a lot of pain relieving things to almost every person I had, we picked the goal time on the treadmill, you know, that they were going to walk and speed. And we spent a lot of time on that because then they could reinforce that at home. And then it was generally, you know, if there was some hope that we were going to get some pain relief in a focused area, you know, what are some things that we can do with there? But, you know, I tried to get away from the fact that they're coming here for me. You know, I used to tell people all the time, you've had this for 20 years and you think I'm going to figure it out? No, but I am going to be able to help you. I need to figure out what I'm going to help you with. But if you're coming here thinking, you know, that I'm the person on the mountain who's going to figure this out for you, you know, you're sorely. All I had to do is tell them I went to WVU for my PT training, and they understood in Pittsburgh. You know, it's like, I'm not going to be able to help you. But it did get the point apart. Yeah. So does that make sense? I wish I had, you know, a better way to do it. And then if, you know, there are people that work in unethical situations, and if you know, if you find that out, then you have to make, you know, the right decision for you. There's a difference between people pressuring you a little bit about your productivity and people, you know, threatening you about it and being abusive about it. Everybody has to pay the bills. I always took it where I worked that they were just reminding me, you know, they had to pay the bills. And you know, that makes sense to me.
Taylor, do you guys have a waiting list? Because sometimes one of the things that you can share with them is that you get reimbursed more for doing initial evaluation than treating a patient. And then the second thing I usually bring up is, do they use stratified care? And if they do stratified care, like a Start Back or an OSPRO or a Promise or some type of prognostic, do they understand the targeted treatment approach? And if they do understand the target treatment approach, then they would know that what they're doing is actually going against what's best evidence out there. So those are really the two strategies I try to use with groups who are trying to overutilize, especially if they're very focused on treatment-based. I think people who are very treatment-based or people who are running their own programs, I think that's the danger behind it. You know, they're trying to figure out how to pay for it. And I think they need to maybe weave in some better evidence to help them recognize how they're doing versus looking at it as a model of fee for service. So that's some strategies I've used.
Yeah, appreciate that. Thanks, guys.
Anything else going on in the chat? I saw a few things. I don't know if any of those, if someone wants to say.
So what I would be interested to hear your thoughts on is, we do tend to get in these kind of silos for wanting rights, such as direct access and, you know, whatever paradigm, imaging, medication, whatever that PT du jour fight is. But really, it seems like the evidence is coming out saying that most of these people likely don't even need PT, or like a large swath of them. So I would be interested in how you think we start getting the community message out to PTs to let go of the reins a little bit, because it sounds like we're going to have some of the same fights that we're running up against with the radiology scenario of, now we're starting to get people who maybe don't even need PT and cutting into the funds allocated to those resources.
Yeah, I mean, it's a good question. And I think that's one of the motivations for Trevor, you know, writing that paper is, you know, there are unintended consequences anytime, you know, you push for something, and you know, direct access is a good example. What may be really good for decreasing, you know, someone's chance of getting an opioid prescription later on down the road may also be, you know, mean you're over treating people who don't need it. And as these, you know, as the value-based care initiatives kick in, if we're not disciplined enough, and there's nothing to suggest that PTs are more or less disciplined than any other provider that has overused, you know, healthcare, whether it's radiology, whether it's injections, you know, there's nothing to suggest that we're more disciplined than that, just so you know. You know, it is going to have some of the consequences that Derek mentioned, which is now you have people that are being overtreated, and maybe they would, you know, maybe they would have gone to the primary care. They referred them to PT, but by the time they got around to that, their back was feeling better. Now they're able to walk into the PT clinic. And that's where I think stratified care could really potentially be powerful, because if you believe in that and you see someone come in and they're low risk, you know, then you should be able to tailor that right away for a very short visit, and sell that to the person that it's a win-win. I mean, I think this is the other issue that we have found and others have found. There's some really nice qualitative research now coming out in the literature about what patients feel when they're told, you don't need an X-ray or you don't need definite diagnosis for your spine pain. And there's a subgroup of them that just don't believe it, and they're going to really, really push back. So it'd be nice if direct access could be a way to kind of mitigate that, where a person is still seeking care and getting some meaningful things, but not feeling like they're being blown off by the health system, because they're not maybe going to be recommended, their condition isn't severe enough to be recommended for an imaging study. So I think that's something else that could pop up. There was some data at Duke. They piloted some co-located primary care with PT. It's not definitive, but it does look like maybe more people were going to the emergency department in our health system in primary PT co-located types of things. So it may be that direct access is good, but it may also mean that people that aren't seeing that physician right away may choose to seek care in a different location than they would normally, especially if the pain remains acute. So I really do think there are some, wide-ranging implications, and I think that's why it's important to define, how that person is entering the system, and is it a PT first? Is it PT treatment first? I think each one of those has potentially different, unintended consequences.
Where do you think PT is gonna best land here? Because some of the Joel Stevens article that you guys just published in JAMA showed that Startback is pretty good at predicting that prognosis, and then you had your non-concordant care, but that was opioids, imaging, and it's just like, I struggle with the idea that just because there are people that are going to persistent care or persistent pain, I don't know that we've seen that PT treatment or conservative treatment can mitigate that, right? Like we continue to see that there are people going to that, but we have no idea if we can even change a substantial percentage of those people going to persistent pain.
No, I mean, I was involved, as you mentioned, with the Target trial. So and the trial paper will be coming out soon. And one of the magic questions for me out of that is, what is a meaningful change in the percentage of people that transition from acute to chronic? We assumed that it would be 20% change, which was way, way overestimated. When you look at the paper, is it Geronimo?
Yeah.
Is referring to other than some of the factors that were predictive, the surprising message from that is how many people from primary care, we got these folks at primary care transition to have chronic pain 6 months later. It was a lot. And there, even the low risk people, there's about a 20% chance, if I remember correctly, about a 20% chance that a low risk person will have chronic pain or meet one definition of chronic pain 6 months later. And as Joel pointed out, we wrestled with how to write that paper up. And I think some of this remained in the discussion. When you look at the volume of that, there's a lot of low risk people that are going to end up having chronic pain. And we're not saying, those people need full on PT, but boy, we need to have, this is where the community parts may come in. It would be nice to know that the 1 in 5, that it's going to transition on has some opportunities to reverse that. But your question about what the transition is and how does PT do that, I think that's a great question that hopefully that work, that observational cohort, will spur others to think about. I do think instead of a 20% reduction, we would probably think more in the range of 5 to 10% reduction might be meaningful. When you look at, when people look at reducing mortality from heart disease and things like that, they don't swing for the fences and say, we're going to reduce it by 30, 40%. They're pretty happy with smaller percentages. And that's where I think we have to start with the acute to chronic. The other thing that PT is great at, though, is we can also have people function much higher, even if they do meet a chronic pain definition. And I think that may be where we have to think about too, is, acknowledge that the person is in pain and they have pain most of the days of the life, or most of the days of that month. But if we can have fewer days where that pain impacts their activities of daily living, that might be a win. But that's a slightly different mindset. That gets a little bit more at the behavioral things, right? Now we're helping that person cope. We're helping them disassociate pain and injury, and we're stressing the importance of maintaining, their functional activities even when they're in pain.
Right. I'm not sure if you saw the mayor study that came out this week of them doing the emergency department, but they pretty much used ibuprofen and heat packs, and they decreased across Australia the opioid usage by an average of 12%, and then 24% in the highest hospital. And I thought that was really interesting because they also took satisfaction and pain levels, and it stayed the same, right? Because that's kind of the problem we're seeing in America right now. Prescriptions are going down, but suicides and pain is still remaining up. So I thought that would be an interesting idea to bring into the American system, just because we saw with that Stevens article that you were part of, that opioid care was also a predictor, right, or a moderator.
Right.
So trying to bring back to heat packs, I guess, but a lot.
There's nothing wrong with heat packs, right? I think heat packs got a bad name because they were no better than placebo in a lot of controlled studies. But guess what? There's a lot of other things that's no better than placebo when you control them that way. And they also were, they're viewed as short-term pain relief. But hot packs are now guideline recommended, and I think the issue is, how much should you charge for them? That's what really has changed. But I think we've started collaborating with some emergency department physicians, and we are toying around with, like, what can we do in the ED that is something like that? Because the physicians just want to give something. Like, you can't say you can't write for opioids, right, and then say, good luck. So she's done some, her name's Steph Eicher. She's done some trials of group acupuncture where they'll refer people to a group acupuncture clinic. My dream is to have them use TENS units in the ED, like give them a TENS unit to take home, and it has a barcode on it. And then that barcode, when they bring it back, pays for their first 2 co-payments at a PT or a chiropractor in the same health system. So they get the immediate pain relief, and then it reinforces that they should probably do some follow-up for a non-pharma provider. And, so I think being innovative and thinking, but it's clear, and obviously they picked up on that because Chris Mayer, I think he knows what he's doing right by now. It's clear when people present to the ED, there is pressure that they want some treatment, and they want more than just, you don't have cancer, or you don't have an aneurysm, you don't have an aortic abdominal aneurysm. They want that, obviously, but they also want to start the path to, cutting that acute pain. But in those sites, we did that study, I think 2015 to 2018. So people were well aware of the opioid crisis. I think overall the sites, it was like 22% of people got an opioid prescription for acute back pain. That was eye-opening, super eye-opening to the study team. Some of the primary care docs were embarrassed. That means 1 out of 5 at the height of the opioid crisis in good healthcare systems. This is Intermountain Health. This is University of Pittsburgh. That means 1 in 5 of them were writing an opioid prescription within 21 days of an index visit, right, for acute back pain. That's crazy, I would like to think the physician knowledge of that's not reflective of the physician knowledge. I think that's reflective of entrenched and reinforced practice patterns, both, just from the social practice of writing a script, and also from the reimbursement. People will travel those well-worn paths when they know they're going to get paid for it, and it moves their clinic along and things like that.
Yeah, I think that that was just what you just mentioned, was the interesting part about their trial, is that what they did is they randomized into giving the physicians education or not. And just by giving them the education, they started using ibuprofen and heat packs, and that reduced by 12%, like I said, on average, but also kept the satisfaction of the patients up.
Yeah.
So like maybe it is just educating these physicians and allowing them, right? Because we try to bring in PT, but that like you said, that's a lot of intervention for somebody in an emergency department compared to something that they're used to. Like here's a heat pack, here's ibuprofen. You know, they're
Yep.
used to doing that.
Yeah. No, Steph, or Dr. Eicher, she's done some really, which we're not doing any trials yet, but she's done some survey studies in the ED, and it's really interesting. She's asked people like how willing they are to try non-pharmacologic, and it has just blown up any misconception that people that go to the ED are just there to seek drugs, whether they're opioid or not. I mean, I think this one paper that we're just about wrapped up, it was like 83% of the people said they would be more than willing to try, and we had a whole laundry list of non-pharma. It was hot packs, it was yoga. And, that was pretty eye-opening to us. So we're looking forward to get that out there, because I think that also will be eye-opening to the providers that these patients are even, and now the next step is to, these patients, when they leave the ED, they can walk past probably 4 opportunities to have an MRI scan. Like there's so much diagnostic stuff there. And now it's like, how do we get these channels where they are actually offered the non-pharma that they said they're willing to try? And the hot pack ibuprofen is a great way. It's a fun, innovative way to do it.
To the point of the emergency department, what are your thoughts on, and I don't know if this is implemented, but someone who is considering going to the ED for back pain, there's a system set in place, whether it's a physician or a PT, where you can do like a quick phone call or telehealth, and whatever they need to do to rule out, sinister things. And then they recommend like the heat pack, the XYZ, the Advil at home. Would that rule out the probability of like having things being done in the ED, since you're not even making it there, but you're kind of getting the same guidance?
Yeah, I mean, it definitely would. I think that one, is there's still a ritual of care seeking for a lot of people. I think that one is, there's probably a subset of people that would be fine with that. And that would be a really interesting thing to pilot, to see how many people are satisfied with that, and it works. So I think that would be a really fun thing to explore, because it does reduce exposure, right, to a lot of things that are going on in that clinical setting that are not guideline adherent. My concern with that would be like, how many people are going to do that and still seek care is that's a huge question related to that. And if it's a reasonable amount, I think you can actually do it. If it's a reasonable amount, you just need to know how much it's going to be, because those people are going to show up somewhere in the system. And you want to make sure, where they end up. Because if you save them the trip to the ED, but they end up in the surgeon's office, that may not be, a win-win.
Most of the people from the ED too has to follow up in primary care. So one of the things that we're seeing a lot of, Chris, to answer your question, is even if they got okay advice, even from the ED, and they're still having a flare up because they're not sleeping well, or they're catastrophizing, or something else is happening in their lives, and they end up in primary care. The Stevens article with Dr. George here, you can read it. The advice they usually get is further imaging if they didn't receive it then, or an opioid or something else, majority of the time. We call it embedding. It's kind of different than co-locating. One of the problems too that we see in primary care that's different than the ED is there has been more time lapsed versus an emergency department. So what can you do? We can actually put them in different treatment approaches now and really be effective with our CPG. We manipulated people when we did our study 35% of the time, and they fit into that. I think there's different things that we can do in the primary care that are different clinical pathways because of the time frame is different than an ED approach. The other thing too that the primary care doctors would tell you is that majority of the patients who come to primary care have more than 4 comorbidities that we're dealing with, and that's why they're there. It's usually a diabetes check, hypertension, and then, by the way, my back's been bothering me, and I have maybe peripheral neuropathy, and you have 20 minutes to deal with this. And so the burden that we're seeing a lot of in primary care, I'm not taking anything away from ED, much love and respect for what everyone's doing. But the reason why we strategically picked primary care wasn't because we wanted to go there. We had primary care providers asking the same question. Can we do better? And can we do more with your help? Is basically what they were saying. They're like, we need different clinical pathways. And the one that we have of sending them to outpatient is not working for us. And the patients are the first ones to say to you, copay and travel time and the wait time is unacceptable for what I'm dealing with. So being there and doing a one-time treatment with a low-risk patient, we did that about 40 to 50% of the time with very, very high patient satisfaction. Very high patient satisfaction. And the rest of them either got other treatment. So talk about a pretty nice position to not just help the community, but to help the providers who are saying the same thing that I think Geronimo was saying with the ER physicians. But the problem is when we talk to primary care physicians, they always think we're just asking for a referral. You have to convince them that you're for primary care. And I think this is exactly why, we all came on to hear Dr. George's talk. It's because he's basically saying value-based care is what you would say to a primary care provider, not I'm here for a referral downstream. Can you send me referrals? Because they're so used to that. You do the greet and meet and here's my pad. And when we said we're about value-based care, they were shocked. And we're for primary care. I mean, they were like, are you serious? I'm like, yeah, we're part of your team now. We're not thinking about, and then the responsibility of not over referring to physical therapy was shocking to them. Being good with a one-time treatment. I think that's one of the things that we're learning about what we're trying to do either in a group or when we're meeting with somebody, is trying to be really good at making wise decisions versus making unwise decisions. And you have to have clinical pathways for that.
Yeah, and the VA related to that, in the VA, we've designed 2 different pathways, and we're doing a comparative effectiveness. We just started it, but the protocol paper is published, and it's kind of, we designed 2 pathways that we thought was primary care friendly. We had primary care stakeholders, and one is what we're calling a pain navigator, where the primary care, if the primary care initiates the referral to our program, the patient spends some time with a pain navigator, and that person elicits their preferences, does some shared decision making, and tries to help them navigate the VA system. Different system than what we're talking about, because it's not a fee-for-service, traditional fee-for-service. So the other pathway is more of a sequenced care that starts with 2 on-site visits, but then it goes to telehealth. And so we'll know about that in a couple of years. But engaging primary care has been one of the challenges. There's some people that we call it the easy button. It's like, if you push this button, this is what will happen on this pathway. And that's really important in the VA, because the VA has all these services, the veterans can have access to them. So we marketed it as the easy button, and for some of the same reasons, that were just mentioned, because it's like, if you refer this person, they're going to talk to a pain navigator 2 or 3 times, and they're going to try to steer them towards non-pharmacologic treatments. That's what the other part of this is. Both of these are ways to keep people kind of out of things that they shouldn't. So.
Does anyone else have any questions? If not, we can wrap it up here.
Hi, I do. So I have a question about a lot of the research is centered around the visual analog scale and survey-based outcome measures. Has there been any consideration of other ways of measuring? Because these are obviously very non-custom, how do I say it? Patients basically say they're frustrating and don't fit them. So is there anything else that's been considered with that research?
Well, I think there's a lot, there's a lot in this space, and I understand people's frustration with, VAS numeric rating scale. So, in research, it's always a push and pull of, do you use measures that are well established, because it allows you to compare directly, to what's going on versus moving forward. I think the issue with pain is it's a subjective experience, and there are probably slightly better ways of measuring it, but when you talk about doing it at scale, it becomes harder and harder to implement. So, I don't have a great answer for you, Mike. I think was the one who asked that. Other than I would keep my eyes on things, but when you talk about trials, pain and some of these measures are accepted primary outcomes, and those are really, really hard to change, because people, when you plan a trial, it's like you need to have information to estimate how big the sample is going to be. So it's a little bit of caught in the middle. What I would be interested in is if the process of capturing those measures changes the perception of those measures. And what we hear is, and I think others have had this experience, if there's a perception that people are collecting it and it's going into this black hole and it's never going to be used again, that leads to frustration. Whereas systems that make it clear that how they're using the PRO and they revisit it with the person, there seems to be some higher satisfaction with it. So I think there's two elements. One is, can we get a better measure of pain? And I would say people are working on that, but I wouldn't hold my breath because of the subjective experience part. Two is, what are processes that we can put in place to ensure that the patients know their information is being valued? Because I think the two frustrations we hear are, one, you've asked me the same thing multiple times now, I'm done, I'm tapping out. And that's a system problem. And two is, you're never going to use this. You can address the you're never going to use this one. There was a really good example I think it was in the New England Journal Catalyst at the University of Pittsburgh, when they started going over the PRO as part of every visit with, I think it was in orthopedics, and the patient satisfaction rating started going up. So it's a little bit of a dodge, that question. It's a good one, but it's also kind of, I think, fairly realistic. Does that make sense though, Mike?
Yeah, it's just, like you talk to I work in a clinic which is like 99% complex persistent pain, and almost every single patient will tell me at some point, well, this doesn't apply to me. How is this?
Right.
Like, we'll ask them like the care connections with the general questions, and they'll just say like, well, this doesn't apply to me. I don't know how to answer this because there's no intermediate answer for this, or I don't know how this would work. And so and like, I'm trying to articulate it, but then I really realize, like, ultimately it's hard when we're so focused on generalizing data to really give somebody something that fits them,
Right.
so to speak. And that's the challenge, because for them, that's like another, like, some of them, well, a lot of my patients are traumatized by the medical system. So for them, it's just another horrid thing that they have to deal with that's just a complete waste of time in their opinion. So I guess maybe articulating like, oh, we're trying to use this for research might help. I just don't know.
Yeah, or we've and maybe there maybe I don't know enough about your patient population. There are places when maybe the measurement isn't a good match, and then you can talk about are there adjunct measures we can put on. But I also, and we talk a lot about this with PTs when we do the psychologically informed, training, is this just one piece of information at one point in time? So don't, when patients sometimes get really hung up, on what their pain score is that day, we really try to reinforce, because some PTs get kind of hyper focused on this, right? And they're like, I want a pain score before you start, after, during, and after, and they're kind of over measuring it. And I'm not saying you are, but I'm just saying, one of the ways we try to communicate to the PT and also to the patient is, this is a way we can get a general reflection of where you are today. It is not, it's not predetermined. It's just helpful to track the same thing over time, and it's not perfect. So that could be another tact, that you could have, because we've all had patients. It does sounds like I haven't worked in the population that you have, where, they'll say, I hate I hate rating my pain 0 to 10. I hate it. I'm not going to do it. And, that's when I say, I can't make you do it, but all I'm asking you for is to give me a number today, 0 to 10. If it's reflective of, even better, but that's it. I'm only going to ask it, and then, kind of go from there. So, but I do think there are pockets, and this is the challenge with measurement. Like you nailed it. The more broadly applied it is, the less applicable it's going to be to certain people. I mean, that's just what we know about measurement. Ideally, we would have an individual measure for everyone, but we wouldn't be able to compare it, across anyone then. So that's the challenge of doing research.
Thank you so much, Steve. This was great.
Yeah, thanks everyone for the turnout and the great questions in the discussion. Good to see some familiar faces too, and good to meet some new ones as always. There's some well-read folks on here. Had to be on my toes a little. I have not read the Chris Meyer one, but I am aware of it. So I'll hunt that one down, Geronimo. Don't be too disappointed in me, but I will check it out at some point. But I hope everyone enjoys the rest of their weekend, and thanks for having me, and we can do it again if it is so desired.
Yeah, thanks again,
You didn't
Steve.
tell me Derek Miles was going to be on. I mean, that's worth it. That's worth it alone. So
yeah, Derek's the man. I was up in California, and he was a mentor of mine when he was at Stanford. So big fan.
Yeah, Derek's a good guy. I've known him for quite a while now, I guess, huh, Derek? Oof.
Yeah, over a decade.
Yeah.
I always try and convey to the social media sphere that one day we're going to drag you out and make you actually join some of these. So I'm happy to see it finally came to fruition.
Yeah. Well, there was not much arm twisting involved. A little bit of calendar confusion, but not much arm twisting involved. So
you're just too popular.
I wish, right? All right, you guys and girls and everyone else have a fantastic weekend. Hope your basketball teams fare well, and thanks again for having me, Chris.
Yep, no problem. All right, bye.
Bye.